Hello, and welcome to our edition of Let's Talk SADS Live, the Canadian webcast by the Canadian SADS Foundation, Sudden Arrhythmia Death Syndromes Foundation. I'm your host, Dr. Shu Sanatani, and I'm coming to you from Vancouver. We're live here in the studio, and hello to wherever we find you today, tuning in after your workday, perhaps, or on the drive home. And delighted to be here to talk about these conditions, inherited arrhythmia conditions that have impacted so many of you in your lives. And so hard to believe we're on episode 32. Thank you to uh, Pam Husband, who had the vision to start these engagement sessions, really where we come together to learn together collaboratively. I say at each session, I learn so much from our guests, and we've had some wonderful guests over these past few years. So, just a couple of things I want to talk about here. I really want to thank our sponsors. We've seen these logos before: Lexio Therapeutics, Solid Biosciences, Tenaya Therapeutics, and Thrive Therapeutics. Um, so what's been happening in the last few years in this space of these inherited arrhythmia conditions is that some very uh, sophisticated companies are getting to the point where they are trying new treatments in conditions that we've used the same treatments for decades, and we're now in a really disruptive phase. And so things like new molecules or repurposing medications that have been used for other things, or even gene therapy, where we are in injecting a new gene, new DNA material. So it's very exciting, and we're very grateful for their support and their partnership really in this, because they, like the Canadian SADS Foundation, are very patient focused. And when setting up these trials, they really have to understand who's out there and how we can help them. And so thank you very much. So this platform, and thank you to our new new CEO Guido McGuigan, who has been working on expanding our footprint and comes with some tech savvy, and he has us now streaming on Spotify and YouTube and Amazon, so people can access these webcasts even more conveniently. Um, so nice to know that you can access this on whatever you're currently using. So, as you know, I always like to give us a little bit of some fun facts and factoids and trivia. So, this is just a shout out to the Canadian Hearts in Rhythm organization. So they are our our partners really in what we do, and congratulations to Andrew Cron, who had this vision a few decades ago, and we just have come back from a wonderful meeting in Quebec City, and Pam and Guido were there and took the stage, and SADS was definitely a partner in this uh, collaboration, where we're really a very Canadian based learning and researching group. We had the privilege of Dan Roden speaking. He's quite well known in the SADS field, and he's done a lot of work um, from Montreal originally. So really continuing with our Canadian focus. It was interesting though listening to Professor Roden, because he's a world expert in many of these fields, but some of the amount of work that goes into understanding some of these conditions is just phenomenal. So it really just underscored the complexity of these SADS conditions. So um, I also came across this, which I thought was very topical. So this is from the Alberta Health Services and a Heart Safe community, supporting your mental health after dealing with a medical emergency. And they talk specifically about cardiac arrests that can have serious and long-term impacts to all those involved. And I did not know that PTSD Awareness Day was coming up in June. So we're just around the corner from the beginning of summer, and 1 week into that, we're going to have PTSD Awareness Day. So, and that really is the the segue into our talk today. But before that, just a reminder that we go right through the summer, and we're looking forward to having Dr. Dana Spears, who is a leader in this field. We're going to be talking about pregnancy with SADS conditions. So she's a cardiologist in Toronto that we've enjoyed working with over the years. So I'd like to bring in our guest today, Dr. Lauren Schneider, and have her join me in the studio here to begin our session. So, Dr. Schneider, welcome. I'm going to take the liberty of calling you Lauren for our exchange today because I've had the privilege of meeting with you a few times and even sharing the stage with you. So welcome today to Canadian SADS.
Thank you so much for having me this morning.
So Lauren comes to us from California, from Stanford. And why don't you just tell us a bit about your journey, sort of how you came to be who you are today?
Sure. So my journey began, I'd say, as a teenager, really interested in the medical field. I started college with the intention of pre-med major and stumbled across the field of pediatric psychology in undergrad. I was working at the Cleveland Clinic and had the opportunity to see different aspects of the world of pediatrics and learned that pediatric psychology fused the field of medicine with the field of psychology and was able to potentially have a really big impact on the lives of patients. And so changed my major, and then after college pursued a graduate degree in clinical psychology, and then pursued postdoctoral training and licensure, and have been on the clinical faculty at Stanford Medicine Children's Health with the Stanford School of Medicine since 2011. And over the years, I've worked with a number of children with different chronic medical conditions, but in the past few years, I've really specialized to working with children and families where the child has a cardiac condition.
And so your current job is on the faculty at Stanford, and what is the job? What's your job title?
Sure. So my job title is clinical professor, and my role is a pediatric psychologist. So I'm working exclusively with patients who have a chronic medical condition. I'm seeing patients sometimes in the hospital during their admission, and the majority of time I'm seeing them during their outpatient medical clinic visits. So I am integrated and embedded within our heart center, and I will see patients during their medical visit and meet with them, their parents, and their siblings. Additionally, we offer services on an outpatient basis, and that's more of a traditional psychotherapy setting in which I'm seeing patients or their parents for psychotherapy, either in person or over Zoom. My role, I'm really honored that it also includes time for clinical research. And also I supervise a number of our postdoctoral fellows, graduate students, and I'm an academic advisor. Really part of the role that I'm very proud of is to be co-director of our Thrive program within the Heart Center. And that's an initiative that we've developed over the past few years and launched 2 years ago to really integrate different supports and points of support for our patients and families. So we have the umbrella of Thrive, which includes psychologists such as myself, but extending far beyond that to our chaplain services, child life, our social work colleagues, and really bringing everybody together to consider ways to best support our patients and families along their journeys.
Wonderful. And the reason I'm getting you to sort of to explain all this is because I think what you have set up and what exists there is really a gold standard almost of what Canadian centers are aspiring to do. And there are certain there's lots of awareness now around the mental health implications of these diagnoses and how patients come into care. We're gonna talk about that. But really to know that it can exist and it should exist is inspiring and gives us hope to keep advocating. So let's sort of dive into things. my impression, and this is, the life is sort of being divided into, pre-pandemic and post-pandemic in some regards. It feels like the pandemic really shone a light on the need for mental health support in society in general, not just this area. Is that your experience as well? Can
Yes.
you talk a bit to that sudden, demand and relative shortage of psychology?
Absolutely. So I think that the pandemic highlighted the need for mental health supports, and highlighted the shortage of that. We saw an increase in rates of mental health conditions such as depression and anxiety, particularly among our youth. I think that the impact of the pandemic brought about challenges that were layered on top of existing challenges and just really were becoming too much for many people to handle. Understandably, I think it was difficult for all of us. And so for many of our youth, they were already struggling and then had even more struggles with the onset of the pandemic. And I think that it highlighted the fact that we need better supports, we need to better meet the needs. And unfortunately, there is quite a shortage of professionals who can meet that need.
I'm gonna put you on the spot, maybe many times, but I'm gonna put you on the spot right off the bat, and because I know you to be a very, very kind and polite person. But do you think that the clinicians like myself, a pediatric heart rhythm specialist, um, do you think that we have sufficient training and experience to go into these places where we're really actually looking after families properly in terms of their mental well-being? And you can be frank.
That is an excellent question. So I'd say that the level of training that is on par with our mental health colleagues, not necessarily. So that, however, does not mean that one should not be asking questions, helping to destigmatize and open the door for this conversation. I think as for those in pediatrics, pediatric cardiologists, your training is really strong and solid. And many of you, I know for you, Shu, can connect with patients on a remarkable level and their parents. Further, you have an immense trust and relationship that has been built, sometimes over the course of years. So to leverage that, I think is really invaluable in being able to ask a patient or a parent, how are you doing? And a simple question such as that is a part of the roadmap project that colleagues have developed to empower pediatricians and general cardiologists to ask these questions and to start these conversations with patients and families. I think sometimes it can be intimidating and overwhelming because then what if the answer is too much or beyond one's level of comfort in terms of responding? That's generally not the case. And a lot of times the families might need some time to come back to that question. But the fact that it has been asked and the conversation has been started is really invaluable. So I'd say that despite not having the same degree of training that mental health professionals have, there's still room to ask questions, to offer support, and to start that conversation because you're the ones that the families are often most comfortable talking to.
Well, thank you. Thank you for the kind words and an important message. And I don't know how well we reach the medical learners and trainees on our webcast. Pam, we might have to take that offline, but an important point to not be afraid of asking that question, even if we are a little bit uncomfortable. So because I am a pediatric specialist, let's talk a little bit about the parent in all of this. So let's consider a child who has now, presented with this new diagnosis, maybe in the most dramatic fashion even. Sometimes these SADS conditions present with cardiac arrest, even, a resuscitation where someone has, maybe a family member has given CPR and, initiated the process. So just speak a little bit about what what you've learned over the years about, how common is this, the PTSD, post-traumatic stress disorder? You know, how frightened are these parents?
Sure. Incredibly frightened and incredibly scared. Understandably, they may have witnessed one of the most horrific experiences of their lives. And so I think that understanding that this process is scary and it's traumatic for everybody involved. While it can be traumatic for everybody, it doesn't mean that everyone does show symptoms or meet criteria for PTSD or post-traumatic stress disorder. But we do see that in a surprisingly high number of parents. In a study we did a number of years ago here at Stanford Children's, we saw that the rate of meeting the cutoff for PTSD symptoms was approaching 50% of our parents. And that's high. I think it spoke to the fact that parents are often present, if not for the event, they are present and taking in all of the subsequent medical care that their child is receiving. That could be surgeries, that could be really traumatic procedures, and that is a lot. I think during the moment, many parents are in survivor mode. Their fight or flight systems really activated, and they are doing what they need to ensure that their child's receiving the best care possible and surviving the event. I'd say that sometimes it is the moment of that event. Sometimes it's the chronic nature of the medical condition that presents after the fact that can be equally triggering and difficult for parents to experience. And so it's absolutely stressful, scary. Their world has been turned upside down. And I think for parents, they have this desire, this innate desire to protect and care for their child. And then an event like this happens and they have to really reset, reformulate how they are there to still protect and care for their child in the most amazing ways, but now working around this really traumatic, scary event.
And I think, it's so important for us to really hear what you're saying here, because we, as healthcare workers, as especially physicians, we're very focused on, what's the diagnosis? How are we going to treat it? We overload the family with information, these things are necessary, but we have to remember the recipients of our care is not just the child, it's the family. Now, the number of people that experience PTSD, I'm worried about. 50% is a huge number. Did you find was there any gender component? Were the mothers more involved, the fathers? Were you able to learn any of those things? Or
our sample was it was higher for mothers or for female caregivers, and so that I think is something to acknowledge, that the sample was including more parents that were identifying as female or as the mother, and so I think, however, whatever role the parent has in terms of being primary caregiver, secondary caregiver, present more often for medical visits or not, these rates can continue to exist. But for our sample, it was heavily with the mothers.
And I'll just, for our audience who are maybe out there listening and relating to this, it's never too late to look inwardly and reflect on your experience with the SADS condition, the SADS diagnosis, and ask yourself, how you're doing. So sometimes let's sort of, move forward a bit in the process. Sometimes we administer, genetic tests, or even without genetic tests, but genetic tests are the most pointed, where we suddenly identify that a parent has, in essence, passed on the condition. So it's not uncommon in SADS conditions, especially in the pediatric realm, where long QT, for example, is commonly passed on from a parent, and the parent may not know that they have had this genetic risk, and the child somehow has a more severe form. And the child, in fact, comes to medical attention, and then other family members are identified. So have you come across some of this in your work where there is this, guilt, perhaps, or, or sort of family challenges when a condition has been passed on to a child?
Yes. I'm glad you're bringing that up, because I think that's one of the unique aspects of many of the conditions that can be associated with SADS. And I think that that level of guilt is present. It can be really consuming and difficult to manage for parents. But I do think that it is something that is okay to talk about. It's okay to acknowledge and to reflect on, and potentially seek some help to work through. I think that the guilt can be compounded with many other feelings, such as the fear that we talked about earlier, sadness. There can be a sense of grief and loss, even when thankfully one survives a sudden cardiac arrest. But perhaps with the diagnosis and aspects of the potential restrictions or changes, there's a loss of what one expected for their child, or for the patient themselves, of what they expected for their future. And so I think that acknowledging that all of these feelings can be present, can coexist, and at times can warrant some additional support to help one through, because they can be complex and overwhelming.
And coming back to the initial sort of the challenge of the diagnosis, the potential that this was, something that was in the family. Do families ever sort of get over the fear or some of these negative feelings, like in your experience in working with families over the years? Or is it just something that, everybody just carries this burden for a long time?
That's an excellent question. From my experience working with families in a similar situation, they can overcome that fear. I wouldn't say that it is eliminated or that it is non-existent, but creating a new normal and an ability to withstand these challenges, to manage the fears, absolutely. That is something that families can achieve at different paces, of course, but I think that one can get there.
And I like you're part of a group called Thrive, and not to be confused with our sponsor, the aforementioned sponsor. So tell us a bit about that initiative and how it sort of works on getting the families back to, some sort of normalcy, or, as you say, the new normal.
Mm-hmm. Sure. One of the goals that we have with our Thrive program is to provide continuity of care, so that the individuals who are providing services, whether it's the psychologist, social work, child life specialist, can continue to follow a family and be a familiar face. We know that some people need more help and support at diagnosis. Sometimes it's down the road when activity restrictions might come into play, or different developmental stages are bringing upon different reactions and challenges. And so we hope to provide a continuity of care and support that is customized and individualized to each family. When we're trying to help them thrive, we're trying to help them create a state of acceptance for the heart condition and all that comes with it. We know that nobody chooses this, and we try to help them find a way to now have it be integrated, but not definitive, if that makes sense. So whether that's for the child, the parent, the family, one way that can play out is helping parents as they're navigating normal parental challenges and expectations, to be considering how their child's health condition can be integrated once again into their life, so that the parent is not being overly protective or shielding the child from experiences that will help that child's mental health and help that family really function and thrive. We know that it can be scary and it's challenging and difficult, but we hope to help parents and families reset and move in the direction of what they're hoping for themselves and their families.
So let me push you a little on that. You mentioned activity restriction and also just getting the parents back to a level of comfort. And as a, in my work, we're often having conversations. In our program, we're very in favor of activity, sport, and generally we are not in the role of forbidding or condoning. We are in the role of helping to develop safety plans, and so. But often the parents are very fearful. Are there some things that you have found particularly worked? I mean, recognizing different families will have their own individual needs, but are there some general guiding principles about how to help the families?
Sure. I love that emphasis on helping children be active and even adult patients be active. I'd say that the general principles to help one move in that direction rely on really strong communication. So amongst the patient and family, the cardiologist, perhaps myself or another mental health professional, to really understand what are the barriers, what are those fears that might be presenting for a parent that is causing them to hold their child back a little bit. Helping the family reconsider what their values are, what can guide them through these moments. If it's quite severe in terms of the fear or the hesitancy, and that then results in the parent maybe not yet willing to help the child resume or initiate different levels of activities or opportunities, we might encourage them to take small steps to see that nothing happened. If there is concern, we would develop a safety plan, as you mentioned, in really close collaboration with the medical team to boost their confidence that there is a plan, there will be steps to follow should something happen that is unexpected. And I think it's these conversations that are helping to create that confidence when that's needed to take. When we need to take that a step further clinically, we're doing what we call exposures, which I'm sort of alluding to in the sense of let's start small and build our way up, helping the parent maybe develop some coping thoughts and tools to challenge those anxious thoughts that understandably are present, and helping them overcome those so that they can ultimately help their child do the things that are important to them.
And yeah, no, thank you for that. The consistent team is such an important factor, and we've seen this, and I'm sure you see it all the time when one practitioner will allow something or be supportive, and another will be a little bit hesitant, and within our physician group, I think treatment and activity restriction are challenging to be uniform on.
Sure.
And the families really struggle with that. So having some continuity and consistency in the conversation I think is so important. Now, teenagers, now that my children are no longer teenagers, I love working with teenagers, but they seem to me like a particularly interesting group of people. In part, it's a very common age to present with these conditions, and so conditions that have been present, the genetic risk has been there for a long time, but suddenly they're in a rapid growth phase and a complex hormonal time, and suddenly their long QT is evident, or they have a cardiac event. What are some of the learnings you've had in dealing with teenagers, and how to sort of bring them in the conversation, how to get them looking after their health condition?
That's such an, I'm glad you're bringing that up. I love working with teenagers, and I'm constantly learning from them. I think that the developmental period of adolescence is so unique. As you acknowledge, there's so many rapid changes that they are navigating for any adolescent. When we then have these complicated medical challenges on top of it, it becomes even more difficult. I think that part of adolescence is developing independence, testing some limits, and there's definitely a degree of invincibility that can be present with adolescents, and should be as they're switching from being a child who's quite dependent to then moving to becoming a more independent adolescent and eventually young adult. That is challenging when we're talking about medical conditions, though, and navigating what they can do to keep themselves as healthy as possible. And I think that, as you mentioned, when some of these conditions are presenting during the adolescent years, it's incredibly challenging if it's then creating differences in their ability to participate in the things that are most meaningful and valuable to them. I think that should there be a change in their ability to play soccer or another sport, that's not only the sport itself, which they might love dearly, but it's also the socialization and a part of their identity that then might need to be reformulated and redefined. And that's hard to do when you're also dealing with high school classes, friend drama, just general challenges of being an adolescent. And so I think that they're definitely in need of additional support and somebody who can be there alongside them as they're navigating all of this, which is incredibly difficult.
Yeah, and great points and considerations. I'm increasingly aware of how rapid the time goes, especially if we're seeing someone, once a year or once or twice a year. That time between, 13 and 18 is, it occurs in the blink of an eye. What age typically are you transitioning patients to an adult program in your program?
Yes. We don't have a specific age cutoff here at Stanford Children's. We instead are considering their developmental stage and what's best for them medically and also as a whole person. So we try to customize that without a specific age cutoff, generally speaking. I'd say that your point about seeing them once a year is so important for all of us to consider, whether we're on the provider side or the patient and family side, because let's say if we start a conversation at 12 about becoming more independent and helping them manage their own care, which is the age that the American Academy of Pediatrics suggests and recommends, like you said, that gives us about 6 years, hopefully more, to have these conversations and to help them set some goals, to trial and error a little bit some of their self-management strategies while they still have the support, hopefully, of a parent or caregiver. And so I'd say that we are trying to be really intentional about having these conversations often, checking in, having consideration for how they can move to that next phase. And it could be in small steps, but helping them and helping their parent too become used to that and comfortable with that change in the independence.
I want to come back to a point you made about the soccer team or the dance, the dance community is not only the activity, but it's also the social support for many of these young people and older patients as well. And it's so difficult. And I always struggle with is it better to be completely isolated from this, or is it okay to have to join them for the coffee after the event that you were not participating in? I don't know that there's a right answer, but it's something that we encounter quite frequently, because people go from 20 hours of an activity to 0 or one or two, and it really changes their lives.
Absolutely. And I think for some, still being connected and being part of the coffee time afterwards, or maybe taking on the role of a coach or an assistant, for some, that's really meaningful and valuable. And for others, that really stings. That it's really hard to be close and not able to do the thing that they love, or not being a part of the team in the same way. And so I think that speaks to the need to just see what is best for each person, whether it's the child or adult patient, having that conversation, having them consider what would be best for you right now. We know what is ideal, and we might not be there just yet, or maybe we might not get to that, but creating that space and opportunity to have that conversation. For some, it's finding something new entirely, but that might take a little bit of time after they're going through the grief and loss process, if you will, of this part of their identity, which is very meaningful.
So in our remaining minutes, I'd like to kind of, not all of us have a Professor Schneider in our faculty, or even access to a psychologist. Are there some reasonable, tools, self-help? I throw around the concept of mindfulness in some of this, but what are some other resources that people can access? Maybe also in the times between their visits with your Thrive team, and sort of how do we do a bit of self-care on the mental health side when we have limited resources?
That's such an excellent question, and I think the limited resources is something that unfortunately is true for so many parts of the globe, and so many different healthcare systems. I'd say that in the absence of that, or as you mentioned, in between, there are strategies that one can try to learn to help them. And I'd say that these are things that benefit all of us, but can be particularly helpful when one's dealing with an incredibly stressful event that often can come with diagnosis or their medical journey. You mentioned mindfulness. I think that mindfulness is something that we all can take away many benefits from, and that's the practice that can be trying to be focused on the present. To be very simplistic, a lot of times when we are caught up in depressive thoughts, we're focused on the past, the coulda, woulda, shoulda, something that we didn't do right. And with anxious thinking, that tends to be things about the future. So maybe catastrophizing, thinking that something really awful is absolutely going to happen, that we're not going to be able to do something. And so mindfulness helps us be present in the moment rather than the past or the future. There's different ways to accomplish that with mindfulness practices. There's some great apps one can practice that can include quick few-minute practices, tapping into deep breathing, which is incredibly helpful for everybody, because we talked earlier at the beginning about the nervous system and the fight or flight response being really activated in these moments of stress. And deep breathing helps our nervous system really calm down, reset. We can then think more clearly, think more rationally, which is helpful for everybody, especially if they're in a moment of high acute stress and trauma. Additionally, I think that there's small practices one can take, even on the worst of days, trying to challenge oneself to think about something that might be incredibly small, but something to be grateful for. That's a really helpful practice that one can begin to think about. And parents and children can practice many of these things together. And that can be really helpful and grounding for a parent and a child to either practice deep breathing, mindfulness, a quick reflection on the day or in the moment, in addition to other tools and techniques from cognitive behavioral therapy, some of which are actually available through apps, workbooks, websites, etc., to help one reconsider a different attitude or a way to think about a situation.
Yeah, those are some great practical suggestions, because I think all of us could benefit from a bit more mindfulness and less busyness
Yes.
in our schedules. Um, so we're just about at time, but I really appreciate you joining us, and you have so much experience and insight into this, the importance. And I think really sort of I think the takeaway from the Canadian SADS perspective is really that this is the mental health part of these conditions is as important, if not more important, than the sort of the medical management of long QT syndrome and things like that we focus on so much. So really, to invite families to check in, and to encourage our care providers to remember this very important aspect, which I think will help both parties. I think it will help the patient thrive, and also the care provider to feel heard and successful. So um, thank you so much for coming, and I look forward to more conversations, and looking more forward to your research. I think anything that draws attention to this, I think, is much needed.
Absolutely. Thank you so much for having me, and thank you to the Canadian SADS Foundation for highlighting this topic and helping all of us to hopefully begin to make a change in this space.
Thank you. Well, some great insights, and we didn't even, I'm sure, capture the many, many experiences that Dr. Schneider has had in helping these families. And what an important part of the healthcare team. And I would encourage all of you, Canadians, especially with some influence in your local communities, to advocate for the mental health supports that these diagnoses uh, require or demand deserve. Cardiac arrest, conditions that carry a known risk of sudden death. That's a very that's a very big, important issue that weighs on all of our families. So um, as always, I've learned a lot, and I've really enjoyed having the opportunity to talk uh, and also reflect on my own practice, working with teenagers and families. So, a good reminder to really to check in with people. So, I'll look forward to the start of summer and seeing you all next month. Dr. Dana Spears, and we're going to talk a little bit about pregnancy and SADS conditions. So we'll see you all then. Thank you.